So I'm Shashi, certified metabolic health coach from DLife, India's first and only award-winning low-carb platform. So DLife, of course, was founded by Anup Singh in 2014, who is an IIT engineer and also an Icons of India awardee. So he also pioneered the low-carb movement in India with the groundbreaking 100 grams carb limit per day protocol for type 2 diabetes management, especially for Indian vegetarians. So in 2020, he also launched the diploma course, Diploma in Low Carb and Metabolic Health, and which is the only NSCD partnered approved program. And of course, me and Anup Singh, we both have co-organized the first conference as well as the second, and now this is the third. So today we have Dr. Nadir Ali. So he is a cardiologist. He's an interventional cardiologist from Texas, USA, known for his expertise in lipidology and metabolic health. With decades of experience, he challenges the conventional view on cholesterol and heart disease, advocating for low carb approach to improve the cardiovascular and metabolic outcome. Dr. Ali actively educates patients and medical professionals on the role of insulin resistance in heart disease, emphasizing the elevated LDL alone is not the primary driver of atherosclerosis. His research-backed insights continues to reshape modern cardiology, and he is a wealth of information, wealth of knowledge. And I think today's 45 minutes may not justify getting everything out of him, but we will do the best to get out of maximum information out of Dr. Ali. Welcome, Dr. Nadir, again.
Thank you, Sashi. Thank you, Anup. It's an honor to be with you guys. It's like I'm back home. So this is very good for me. I would enjoy.
So, Dr. Nadir, you are basically from India. From which place?
I'm from Andhra Pradesh. At least it was Andhra Pradesh when I left. Now it's Telangana. I'm from Hyderabad. I went to Gandhi Medical College. And then right after medical school, I've been in the US ever since. I've been here approximately 38 years.
Yeah. Good to know. So, you know Anup's background. My background is I was in pharma. So for 35 years, I was a pharma salesman. So I was meeting cardiologists, diabetologists, and promoting all products, including statins, on which we might discuss a bit today.
Sure. Now, I know about your platform for a long time because in the beginning, I interacted with you a little bit on Twitter.
Yeah.
And I have referred so many of my patients to DLife because of any vegetarian who comes in who wants to be on a low carb program up until recently, because now I have another IIT professional here, Ravi Krishnamurthy.
Yeah.
I think he's the one who kind of hooked me to you.
Yeah.
And he is doing some seminal work for the local community for vegetarians who want to be on a low carb diet.
I think it's only thanks to him I could reach you.
Yeah, it's heartening to know. It's heartening to know, so many IITians are getting into this field.
Well, they are critical thinkers. Engineers are critical thinkers, so I'm not surprised.
So the first question, I'll ask this very, very simple, basic question, which we all know that it seems to be very oversimplified, or is it the critical cause that is LDL really the primary driver of heart disease?
Yeah, I looked at all your questions. They are some of the best questions anybody has ever posed to me. And LDL, I would like to challenge that LDL is not a driver of coronary artery disease at all. I mean, that doesn't mean that it is not associated with it. Association doesn't mean causation. And I think if you tease out all the specific details about LDL, I would label LDL as a firefighter in preventing injury, in preventing the injury-related repair mechanisms that leads to atherosclerosis, rather than being an arsonist. It's not causing the fire. It is in there to repair the damage and help heal the injury-related aspects of vascular system. So to blame LDL as a cause and to think in a simplistic term that reducing LDL will reduce atherosclerosis is very naive and essentially wrong. So I'm not prepared to accept that LDL in any condition, like for example, small dense LDL in the setting of insulin resistance, in the setting of high triglycerides and low HDL, is actually causal in atherosclerosis. It's definitely associated with it, but saying that it is causal is going too far.
Thank you.
That's kind of a little broader overview. Go ahead.
Yeah, Dr. Nadir, this ApoB is now being pushed as the superior risk marker compared to LDL-C. What does it truly represent? That is part one of the question. And should it replace LDL in risk management or assessment?
Correct. So yes, that's an excellent question. So ApoB is the protein, is the apolipoprotein that is associated with an LDL molecule, but it is also associated with VLDL. So let's tease that out further. So as you know, cholesterol is a fatty substance that does not dissolve in water, and blood is aqueous. It is water in nature. Blood is water-based. So in order to carry fat, our body has developed these ingenious molecules which are called lipoproteins. So lipoproteins have a phospholipid bilayer on the outer coat, and there is a identifying protein for LDL, which is called the apolipoprotein B. And the inside of this lipoprotein, you have cholesterol, you have triglycerides and such. So apolipoprotein is the apolipoprotein B is the specific protein that is associated not just with LDL or LDL cholesterol, but it's also associated with VLDL cholesterol. So what is VLDL cholesterol? VLDL cholesterol is something that contains a large amount of fat as triglyceride. So it's triglyceride rich, cholesterol poor lipoprotein in the blood. So when your ApoB is high, it may be high because you have high LDL, but it's probably also high, not probably, but it's also high if you have high VLDL or have high triglycerides. So that's an important concept to recognize. As you know, statins and PCSK9 inhibitors reduce the amount of ApoB, so they reduce the amount of triglycerides to a small degree. They reduce the LDL or cholesterol levels associated with LDL to a large degree, but they do it, in my opinion, the wrong way. So to give a one-liner answer, and I'll expand on that, the focus on ApoB is another little propaganda by the pharmaceutical industry to increase the use of statins and PCSK9 inhibitors. And it is essentially wrong, because if ApoB is high and your triglycerides are high, the best method to reduce the triglycerides is through the lifestyle that we all promote, which is a low-carb diet, which is physical exercise, which is fasting. The reason I'm against statins and PCSK9 inhibitors reducing the VLDL portion of triglycerides, I'm also against reducing the LDL portion of the ApoB, but the ApoB that's associated with VLDL is because it does it the wrong way. What do I mean by that? What I mean by that is that the statins and PCSK9 inhibitors, mostly PCSK9 inhibitors, increase the receptor, which is the VLDL receptor, on the liver, in the pancreas. So essentially, your liver is sucking up fat from the bloodstream and gets fatty liver. Essentially, your pancreas is sucking up fat from the bloodstream and it becomes fatty pancreas. So you get pancreatic dysfunction, you get fatty liver, you get visceral obesity. So you are essentially doing the wrong thing and looking at your blood work and saying, hey, my blood work is right and I'm getting healthy, whereas you're essentially getting unhealthy. So the right way to reduce triglycerides is very different. So I'm sorry, that was a long answer, but ApoB should never be used as a marker for improving your health, at least through statins and stuff.
So there's something which is what of late we are seeing, at least in US, that essentially they're talking about more about ApoB. The other factor they're talking about is lipoprotein small a, which is often described as a sort of genetically determined risk factor. So how do we interpret it in the context of overall cardiovascular risk? Is it really a risk? And now there's a sudden rush for this because of new drugs which are coming in, which are on the anvil for lipoprotein reduction, which was essentially always ignored in the past.
Correct. Lipoprotein A is a complex molecule, and I would really advise most of the viewers who want to get an in-depth view of this to go look at my LP(a) presentation on YouTube. And I really think that the data with lipoprotein(a) is more in favor of protection because people with high LP(a) have lower cancer risks, lower mortality. There is no real difference in the risks of cardiovascular disease. The way, and I don't know if I can use one slide to talk about LP(a), or would you think that
Please use.
Okay, so I'm going to pull that up. I'm going to pull that up right here. Okay, so there is this LP(a) presentation. So I should go to share my screen. I don't know if I have permission.
It is enabled.
Okay, it's enabled. Excellent. Okay, so I'm going to kind of just show a couple of slides out here. So what is LP(a)? So this is an LDL molecule, and to an LDL molecule is attached a kringle. So it's called a kringle because it resembles a Danish pastry. And what this kringle is essentially a decoy for plasminogen. So in other words, when our body is forming a blood clot, the blood clot activates because the clotting mechanisms creates a blood clot. But there is a fine balance between creating blood clot and dissolving blood clot. And in order to dissolve blood clot, because if the blood clot becomes too exuberant, the body converts plasminogen to plasmin to break down the blood clot. So what LP(a) is doing is that it's a decoy. It comes in and it looks like plasminogen. So the factors that activate plasminogen get taken up by LP(a), and you don't activate plasminogen to plasmin, so the blood clot stability remains. So in other words, the blood clot remains stable. So why is LP(a) important for us? The reason it's important, and I will not go into an exquisite detail because I want to talk about other things, is that it is helpful in wound healing. So essentially, it heals the wounds. Now, statins, in this slide, you can see that when you take statins, the LP(a) levels actually go up. So like Shashi pointed out, as far as statins were concerned, nobody talked about LP(a) because statins do nothing to reduce LP(a). However, if you now come here and look at a study in which it evaluated what does LP(a) do, and you will find that there is reduced mortality, reduced cancer risk, and I was trying to find that slide, and maybe I will not find it in time. But it, like I had said, it reduces mortality, it reduces the risks of bleeding, it reduces the risks of intracranial bleeding, it reduces cancer risks. And the reason it does that, I think, is because it's intricately involved in wound healing. Now, PCSK9 inhibitors reduce Lp(a) dramatically. Is that going to help us? I don't think so, because I have several women in my practice who have Lp(a)s, and I'm going to stop sharing the screen because I don't find the specific slide right now. I have several women in my practice who have very high Lp(a) levels, and they have no coronary artery disease. So I would say Lp(a) is the wrong marker for us to look at. And I'll make one other point. People say that Lp(a) levels are genetically determined, and I agree with that. But there's plenty of data that talks about Lp(a) levels going up in specific situations, such as a myocardial infarction, such as sepsis. In sepsis, it goes down, and as the sepsis gets better, the Lp(a) levels come up. So those are important aspects to recognize. And at this point, I would say that there is no firm evidence that Lp(a) is causal in coronary artery disease, because there is plenty of data in both directions.
So, Anup, before you go ahead on Lp(a), I have two questions. It is said that Lp(a) causes aortic calcification.
Yeah. That is correct. I did not talk about that because I did not want to go into a diversion, but the association of Lp(a) with aortic valve calcifications is very strong. How causal it is in that, I don't know. So whenever somebody has aortic stenosis, I'm in the habit of measuring their Lp(a) levels to see whether they will have a higher risk of progression. And I think essentially what Lp(a) is indicating out there is that the turbulent forces, because in aortic stenosis, the valve is very small and the valve creates turbulence. And turbulence is associated with injury. And whenever there is injury, there is healing mechanisms, and that's why Lp(a) is there to heal the process. And whether in the process of healing it increases aortic valve calcification is well known, but is it causal? Perhaps. I'm not sure.
Thank you, Anup.
Yeah, to extend on that, expand on that basically for a better understanding. Let's say if somebody has got LPA 5.0, LDL 150, how do we interpret this? And insulin resistance 1.3.
Oh, you mean the HOMA-IR is 1.3?
Yeah.
Somebody
Yeah.
has an LDL of 150, and then they have an Lp(a) levels,
5.0.
like it's 70. Go ahead. So that 5.0, what does that mean in your, because there are several ways of measuring Lp(a). Is that high or low? The
No, it's,
Lp(a) level.
Milligram per deciliter.
Yeah.
Low.
Low. Okay, yeah. So that, of course, it would be low. I don't know what that means at all, to be honest with you, because you are just marginally insulin resistant. I don't know what this person's triglycerides are, but let's say that they are low, and let's say their HDL is high. I would just say that those Lp(a) levels mean nothing.
Thank you. Now, the question is, LDL has always been a concern, but you have already said, there's no importance to it all by itself. But if there is metabolic context attached to it, like insulin resistance versus metabolic health and LDL, how does that, impact the overall interpretation as such?
Again, that's a fabulous question. So the question really is that, is LDL of any value to measure? And of course it is, because it gives you an idea of your metabolic health. So like, for example, somebody who is insulin resistant, they have high insulin levels, they have high HOMA-IR, they have high sugar levels, high A1C, and let's say they also have high triglycerides and low HDL. By design, these people will have a higher number of small dense LDL particles. So they will have the overall pattern of their cholesterol, LDL cholesterol as pattern B, and the overall size of the LDL would be smaller. So what does that mean is that you have metabolic ill health. The LDL particles are to some degree damaged, because what is the primary function of LDL? Primary function of LDL is to dampen inflammation, to be around a site where there is injury so that it has antioxidants in it. It has CoQ10, it has vitamin E. The phospholipid layer of the LDL is also an antioxidant. So what it is telling you in a metabolic ill health milieu and looking at LDL particle size is that you are creating some degree of vascular injury. Better improve your health. Better get rid of insulin resistance. Better get rid of the inflammation. Improve your LDL from small dense to large buoyant or larger LDL particles, because that's a marker of health. In my opinion, what it is not telling you is to take a statin, because that is trying to take away a firefighter, which is involved in wound healing, in vascular repair. It's telling you to improve your metabolic health. Go exercise, do fasting, become a part of D-Life India and learn how low-carb diet functions, especially if you're an Indian vegetarian. That is the context in which I view small dense particles. I don't view that context and say, hey, this person has small dense LDL and hence automatically he's in the category of people who needs a statin.
So
Yes,
does
Shashi.
does it mean that insulin resistance affects the particle size of
Absolutely.
LDL?
Absolutely. When you're insulin resistant, your triglycerides are high, your HDL is low, and because LDL is there, insulin resistance is also associated with vascular injury, with inflammation. And so your LDL is going to be small and dense and not large and fluffy.
Yeah. Anup?
Yeah, there is opinion, I would say opinion or claim that high LDL along with high ApoB is still atherogenic, even on low carb diet. How would you counter this argument?
That's such a good question. So in other words, high LDL is always atherogenic and no questions asked. And there are several ways of answering that. I don't think anybody has a definitive answer. So I don't claim that everything that I'm saying is substantiated with science. It's substantiated with common sense and pathophysiology, but that is not proof. So high LDL, whether it's atherogenic or no, you can look at it through two ways. Number one way is to look at familial heterozygous hypercholesterolemia. So these are individuals who are born with a defect in their LDL receptor who have a lifetime of high LDL levels. So if you look at several of these cohort studies, several people, several families that have been followed, they live just as long or longer than people born with normal LDL genetics. So in other words, you should see that familial hypercholesterolemia people should have an early cardiovascular death, shorter lifespan. That is not the case. And David Diamond has several presentations that will substantiate what I'm telling you. The second aspect of this is that high LDLs are associated with lower risks of diabetes, and that has been well substantiated in this population. There is a lower risks of infection. There is lower risks of cancer deaths. So these people are living longer, perhaps because they are less susceptible to infection, less susceptible to cancer deaths, and they have a lower incidence of diabetes. So that is one evidence that high LDL may not be culprit in atherogenesis. The second evidence is coming from lean mass hyperresponders. This is David Feldman's work, and he's got the lean mass hyperresponder study, in which people who have had at least 4 years of high LDL, low triglycerides, and high HDL have had lower progression of plaque or comparable progression of plaque. If anything, a little lower progression of coronary calcium compared to individuals, matched individuals for their age, who did not have the same blood physiology. So these groups are providing evidence to us that that is not the case. Now, I could take you through numerous clinical studies in which you could say that the emperor, the statins, does not have any clothes in terms of reducing mortality in the way that you would predict by reducing LDL. But that may be another point I think you have to discuss. So I think we can explain that the association of ApoB with atherogenesis and mortality is not well substantiated. In fact, the data is in the other direction, and it's coming out now.
Do statins really reduce the morbidity and mortality? I will say in two classes. One is one who are diseased with insulin resistance, high blood sugar, and another who was metabolically healthy.
So yes, so what Shashi is saying is that, hey, use statins in people who are insulin resistant, who are metabolically unhealthy, and it may help in that group. And I'm challenging that notion, because to me, it needs to make sense. So let's try to dissect this out. So number one issue with statins is that they will affect your mitochondrial function. Mitochondria need CoQ10 for them to function properly. And statins, and everybody agrees that statins reduce CoQ10 function because there are 25 different steps in the body through which we make cholesterol, and statins stop cholesterol production at the 5th step. At about the 20th step, the cholesterol synthesis pathway diverges and makes CoQ10. So when you affect CoQ10 function, and mitochondria, they're everywhere in the body. They are more numerous in the muscles, but they're also there in the brain for brain function. So you would get myopathies, perhaps over 2 to 3 decades of statin use, you would get sarcopenia. In other words, you lose muscle mass. It will affect your brain function and cognition because, as you know, there is a blood-brain barrier, and blood-brain barrier prevents any cholesterol or any CoQ10 from crossing from the blood into the brain. So in a sense, the brain protects itself by making its entirety of cholesterol, its entirety of CoQ10. And statins cross the blood-brain barrier and reduce cholesterol production in the brain. And so you would have lower CoQ10s and in your brain cells, and consequently, it can affect your cognitive function. Statins can make you a diabetic through several different mechanisms. So like, for example, when you take a statin, you increase fat absorption by the liver and the pancreas. So your pancreas becomes fatty. You can become a diabetic through that mechanisms. Another thing is that the insulin receptor is in a part of a cell membrane that is very cholesterol rich. So the orientation of the insulin receptor depends on the amount of cholesterol in your cell membrane, and statins can potentially reduce the cholesterol and can cause insulin resistance. Similarly, they can affect testosterone function. Similarly, LDL molecule is a very important in host defense and in inflammation. So when all of these things, the background of your pathophysiology is put into perspective, and from that background, you evaluate clinical trials. There may be about 1,000 clinical trials that have been done on statins to reduce cardiovascular mortality. And if amongst these thousands of trials, I pick the one trial that showed the maximum benefit and never ever been duplicated, then that would be the 4S trial. The 4S trial was the Scandinavian simvastatin study. And in that study, these people had secondary prevention. In other words, these people already had established heart disease, bypass surgery, stents, or heart attacks. So in that group of patients, if you treated 100 people for a year, you would reduce mortality by 0.6%. What that means is 99.4 treated for a year would not benefit. 0.6, or a little more than half a person of the 100 would benefit. So that's a very small degree of benefit. And this is something that should always be emphasized to a patient before a statin is given, not the relative risk. What they did was they changed that to relative risk of 42% because that appears very impressive. So the robustness of data means that this data should be duplicated. It should be such that any clinical trial that you do with a 25% reduction in cholesterol should show a similar reduction in mortality. And if you reduce cholesterol even further, you should have a larger reduction in mortality. But since then, and it's also worthwhile pointing out that the 4S trial was done completely by Merck, which means that it was done by the pharmaceutical industry. They gathered all the information. They had all the biostatisticians. They wrote the abstract. This data, this case report forms have never been publicly shared. So if you look at case report forms, you can say, hey, what is the robustness of this data? So there is conflict of interest associated with that. Now we move on and we look at other clinical trials with atorvastatin versus simvastatin. Atorvastatin is a more powerful cholesterol-reducing drug, and it will reduce cholesterol even further, up to 50%, the LDL cholesterol. So you should achieve a higher mortality reduction with atorvastatin versus simvastatin. This was not shown. If you move further and look at CRESTOR and the Jupiter trial, and mind you that that was primary prevention, but cholesterol reduction was 53%. And over 1.8 years, the reduction in mortality was 0.27%. Maybe it was 0.35. So it's really very minuscule. Then you move on to the Fourier trial, which is the trial with PCSK9 inhibitors, 14,000 patients in each group. The cholesterol in the PCSK9 group was reduced by 70%. So in other words, their LDL cholesterol was 30 milligrams per deciliter. So when you reduce cholesterol that much, that especially LDL cholesterol, and if LDL cholesterol is a culprit, and if you want to validate your hypothesis that LDL is causal in heart disease, you should have a significant reduction in cardiovascular and total mortality. What happened? The mortality in the PCSK9 group with 70% reduction in LDL actually went up. So how are you substantiating the cholesterol hypothesis based on statin use or PCSK9 use is something that I find very difficult to fathom. And I don't know if you would agree with me when I talk about, of course, I'm talking to the choir, but this is not something that gets across any group of medical professionals.
Anup,
Anup,
you're
muted.
muted.
Sorry about that. Yeah, if LDL isn't the primary, driver of heart disease, then what markers should people focus on instead? That's
Again, absolutely great question, right? What is something that we should look at? We should look at metabolic health. And metabolic health primarily would be, consider using a CGM, see how much your blood sugar spikes when you eat a specific meal, and design your meal such that you have lower blood sugar spikes. Look at your insulin levels, see how insulin resistant you are. Look at the health of your pancreas. Are you making good insulin, or is your pancreas dead? Look at inflammation markers, CRP, GGT. Look at your liver health. Is your liver healthy? These are the things that I would look at. I would also go a little further and say, focus on seeing if you have enough muscle mass. Because if you don't have enough muscle mass, you are at risk of future injury, future risks of diabetes. Protect your muscle mass, protect your mitochondria. And the way you are going to do that is by eating right, by fasting, and by exercise. And none of this involves any drugs. All of this is lifestyle oriented. And perhaps that's the reason why major medical industry, physician industry is so prescriptive. It's so much easier to prescribe a medicine rather than talk to people about lifestyle. So we are really not focusing on the primary drivers of vascular disease, which is metabolic ill health. And that's what this platform promotes. And I applaud you for that.
Thank you.
Just to add to this, as a coach, so I came across to two mentees or two clients. One of them had been given angioplasty 4 times, re-angioplasty in 7 years, and his insulin resistance was very high. It was HOMA-IR was above 7. And the other one is a doctor actually. He's actually a doctor practicing in US, a general practitioner. He couldn't understand why he got stented 4 times in 5-6 years. When he came to me, I asked for blood markers, specifically insulin resistance. He had a super high insulin value, fasting insulin, about 20. And again, his insulin resistance was M7. And when we put him on a low carb and high fat diet, paradoxically, everything came down. Insulin came down, even triglyceride came down, and he saw one of the highest HDL he has ever seen in 2 decades. So this is just to add to what you say.
Well, thank you, Shashi.
So my other question is, what is the role of inflammation in heart disease or atherosclerosis?
I think it plays the key and primary role in heart disease, and inflammation can come because you have insulin resistance. Inflammation will lead to vascular injury. Vascular injury requires repair. In the process of repair, the LDL can get into the vessel wall. It can be taken up by the macrophages because oxidized LDL cannot be taken up by the liver. It alters the LDL receptor. Now it's been taken up by a different set of receptors called LOX receptors into the macrophages. So there is plenty of evidence that inflammation, whether it is mediated through high blood pressure, whether it is mediated through poor sleep, whether it is mediated through insulin resistance, whether it's mediated through infections, will definitely lead to vascular injury over time. And that is the primary driver of our ill health, and that's what we should focus on. How can we reduce it?
Yeah, Anup. So
Yeah, I would know on inflammation part again, I'll quote some numbers. HSCRP 0.7, ESR 2.0, fasting insulin 5.5. So, any need to worry about it, or it's good enough?
Looks fantastic, right? Your CRP is very low, it's less than 1. Your fasting insulin
Yes.
levels are 5, but you always look at fasting insulin in the context of blood sugar. So if that means if your HOMA-IR is
FBS,
very
yeah,
low, go ahead.
yeah. Fasting blood sugar was 95, so HOMA-IR is 1.3.
Yeah, really not bad. I mean, just slightly above normal, but it could be that insulin release is cyclical. So fasting insulin 5 could be, depending on when you drew it, it could be 2.5 to 8 for an insulin level of 5. So yes, so I would say that this person is on the healthy spectrum.
Okay, then this person is me, 14 years after type 2 diabetes without pills.
So see, this is what is very important to understand, is that there are a group of people, I mean, especially people who have critical thinking like you. And in my experience, I have several IIT engineers who come in, they have a hemoglobin A1C like 15 or 14 or 12, and they get diagnosed and they get put on all these medications, and they don't understand why they are on medicines. They look into YouTube video, look into alternative sources of information, and they come see me from like 1,000 miles away, like from different cities. They book a ticket to come see me, and I feel so bad for that, because medical profession is failing the general public. They're failing the general public because they say that diabetes is an incurable disease. It's not. Diabetes can be cured based on how you modify your lifestyle. Now, I should say it cannot be cured in everyone who's got advanced pancreatic damage. And like Shashi mentioned, the specific physician from US who had 4 interventional procedures, he did good on a low-carb, high-fat diet. But as a group, we should always be for science and data, because not everybody who goes on a low-carb, high-fat diet will improve, because a high-fat diet in people who are severely insulin resistant, who have very high triglycerides, in many cases can cause lipotoxicity or fat toxicity and make insulin resistance worse, can make their diabetes worse. So it has always got to be tailored to the individual with follow-up of their blood work. And I have, I get a lot of hate mail when I say that low-carb, high-fat diet is not appropriate for everyone, that there is this phenomena called lipotoxicity or fat toxicity. And many people, when they have advanced insulin resistance, may need to start on a diet that is high protein, low fat, low carb, and focus on fasting and exercise, at least initially until their health improves, is something that should also be looked into.
yeah, in fact, we do that. It doesn't, when we say low carb, high fat, doesn't mean that we give tons of fat. No, it just comes naturally with food, and we don't advocate too much added fat. And essentially, it is on the lower side, not on the higher side. But significant reduction in carbohydrate actually helps immediately, and we have seen that. And our admiration is mutual. You have been recommending people to D-Life, and even we have been recommending some people to you. In fact, 3-4 months back, I had one person coming from US with very high lipids, very high total cholesterol, very high LDL, and low triglyceride, low insulin. So she was panicky. So I told that I cannot take a decision as a clinician. You please see Dr. Nadir Ali. He's in Texas. I don't know if she got back to you, but she had super high total cholesterol and LDL. So our admiration is always mutual, and For many of my clients based in US, I always take your name and tell them to consult you in case they have any worry on the lipid front. So that is,
Thank you, Shashi.
thank you. Anup, you
Yeah.
want to say
Personally,
anything?
Dr. Nadir, personally, Dr. Nadir, I would, I think thank you would be not doing the justice for recommending and praising D-Life. Yes, we've been doing our bit in this space, and as usual, these things are not accepted very fast, but yes, still we are moving ahead. And thank you once again for praising. And yes, before I end, I would like to invite you to the podcast that we hold any day, anytime, whenever it suits you.
I would be honored, Anup. Go ahead. Sorry.
So before we leave, I wanted to give one message to India, keeping in mind the current circumstances in India that we are all metabolically ill, with high incidence of diabetes. What would you recommend? What is your final take?
Definitely, like I would like to say that Indian diabetes is very different. Indian people become diabetic at lower weight, and they are not like Caucasian diabetics. So the Indian pancreas doesn't make a lot of insulin for whatever reason. So I would say that you focus on muscle building, you focus on fasting, you focus on a diet that is not giving you a large amount of carbs. And so that would be my my recommendation.
Thank you.
Yeah,
Thank you, Dr. Nadir.
before we end, a special invitation again. We would love to have you on our podcast whenever you are free, and time and date is your choice.
I'm going to create time for you because you all are so important to me. So Shashi, just send me an email and I'll agree to whatever time frame you want.
Thank you.
Thank you. Thank you, Doctor.
Pranam.
Thank you.
Thank you.
Pranam.